Assalamu alaikum wa rahmatullahi wa barakatuh, dear colleagues and friends. I hope that you are all doing well and fine. New discussion, new topic, new task for the new batch for May 2025 exam. Actually, very important topic, post-coital bleeding. It's not only for the purpose of the exam, but also for the clinical practice and for your daily work. Let's start by a story to explain what is the importance of post-coital bleeding. In 2017, a 49 years old woman tragically lost her life due to cervical cancer. A coroner's inquest into her case revealed critical failures in her care. The smear test was inaccurately reported, and two subsequent opportunities to identify the clinically obvious cervical cancer were missed. This devastating outcome highlighted significant gaps in the investigation and management of post-coital bleeding in UK. And this promoted a widespread discussion and reflection within the medical community. That's why the Royal College published a TOG article in 2022 about post-coital bleeding. And since that time, it has become a recurring topic in the exam in part 3. In 2023, there was a task about the post-coital bleeding and emergency contraception. This task will be added to the PDF of the sexual and reproductive health module, and another task about the unexplained post-coital bleeding, how to investigate and how to manage, and this task will be added in the general gyne module PDF by Dr. Ali. So, emphasizing its clinical importance and the need for investigation and the management of cases of post-coital bleeding. So, in this lecture, we are going to review the most common causes of post-coital bleeding, and we will discuss the structured framework for history-taking, examination, and initial investigation with the goal of improving the patient outcome and preventing misdiagnosis of this common symptom. So it is important from the clinical practice point of view and important from the exam point of view. In the exam point of view, we are going to discuss it in two separate tasks. And as I mentioned in the subfertility, sexual and reproductive health module with the emergency contraception, and the other one in the general gyne module for unexplained post-coital bleeding. So let's start by the definition. What's post-coital bleeding? Post-coital bleeding, this is a non-menstrual bleeding, not related to menstruation or even spotting. That's not related to menstruation and occurs immediately after sexual intercourse. It is a common symptom occurring in about 9% of women. The main aim of the investigation here is to exclude cases of cervical cancer. Most women with post-coital bleeding will not have an underlying malignancy, despite it is the most common cause. But most women with post-coital bleeding will not have an underlying malignancy. It is reported in the studies that between the age of 20 and 24, the incidence is 1 in 44,000, and between the age of 45 to 54, it is the between 1 in 2,400. So the incidence will increase with age. So the purpose of our discussion today is to review what are the common causes of post-coital bleeding. Let's discuss what are the causes of post-coital bleeding. It may be due to benign conditions like urogenital atrophy. We are going to discuss it. Any vascular tumor of the genital tract, if there are any polyps, any ectropion or cervical erosion, and this will be discussed with the case of emergency contraception and cervical endometriosis. These are benign conditions that may cause post-coital bleeding. Infections, especially in the young age, that may lead to cervicitis secondary to chlamydia and gonorrhea, vulvovaginitis secondary to candidiasis and trichomoniasis, and endometritis, which may occur in presence of IUCD. There are vulval conditions like vulval dermatosis, if there is genital wart or genital ulcers or syphilis. Also, the most critical part of the most critical cause of post-coital bleeding is malignancy, like in cases of vulval, vaginal, cervical, or even endometrial cancer. There are other reasons. It may be due to trauma or genital piercing, maybe due to bleeding disorders or taking anticoagulant, foreign body, or sexual abuse, or it may be due to related to pregnancy or female genital mutilation. These causes are very important to be excluded when you are taking the history. That's why the information gathering domain here in this task will be full of information that you have to collect it. After the history taken, we need to do a thorough examination to exclude any other causes and to exclude the possibility of malignancy. There are initial investigations that has to be done, and we are going to discuss what are the indications for referral to secondary care or colposcopy. So we need to put a management pathway for women presenting with post-coital bleeding, because till now there is absence of national guidance in UK. So what is included in the history or in the information gathering? As we mentioned before, relevant history or targeted history means the presenting complaint and the risk factors. Here you have to analyze the presenting complaint, which is the post-coital bleeding, search in the history about the risk factors for malignancy and the signs that are suggestive of underlying pathology. So in the history, you should inquire about the patient age. We mentioned before that the incidence of cervical cancer increases with patient age in cases of post-coital bleeding. The menstrual history, including the last menstrual period, to exclude pregnancy complications. If there is any other gynecological symptoms like discharge, pain, or dyspareunia, contraceptive history is very important because the combined oral pills and the hormonal therapy may lead to cervical erosion that may end up with post-coital bleeding. The HPV immunization is very important because it reduces the incidence of cancer. Cervical screening history if the woman is more than 25 years old and if she had any previous colposcopy or treatment. The sexual history and sexually shared infection, especially chlamydia in ladies less than 25 years of age, where the incidence of chlamydial infection is 7%. If there is relevant medical or surgical history, as we mentioned, if there is any bleeding disorder, if she is taking any anticoagulant, and if there is any relevant risk factors that, like smoking, that increase the risk of cervical cancer. And it's very important in the information gathering domain when you are collecting history from a patient with post-coital bleeding is to exclude the possibility of domestic or sexual abuse. This is a very important and mandatory point in the information gathering. It's a failure point of the information gathering if you did not ask a patient with post-coital bleeding about the domestic and sexual abuse. And here, because it is a very sensitive topic to inquire about the intimate partner violence, there is a screening tool called HARC screening tool. There are 4 questions here that will explore if there is any humiliation, if the patient is afraid of the partner, if she has been exposed to rape or any physical abuse. This screening tool will be discussed in details in the antenatal care module in the task of domestic abuse with Dr. Ali. So these are the points that has to be covered in the information gathering domain. All of them are very important points to identify the risk factors and to search for any signs suggestive of underlying pathology or malignancy. The next point after information gathering will be the examination. Here we have to do an abdominal examination to exclude any pelvic abdominal pathology or possibility of PID. Careful inspection of the vulval skin, as we mentioned, to identify any vulval condition like dermatosis, erosion, ulceration, fissuring, or piercing, which is a common practice nowadays, and female genital mutilation. After inspection, you need to do cascospeculum examination. We need to inspect the vaginal wall for any atrophic changes or ulcerations or prolapse, the vaginal discharge and the foreign body, and you have to take swabs. If there is any cervical ectopy or polyp, and invasive cancers will be clinically apparent. There are findings suggestive of cervical cancer that include ulceration, presence of friable tissue, contact bleeding, or irregular fleshy mass. So, after abdominal examination and an inspection of the vulva and the cascospeculum examination, you have to conclude your examination by doing bimanual examination. Palpate the cervix, because fixed cervix and the infiltration of the parametrium is a sign of advanced cervical malignancy. You have to assess the size of the uterus, search for any adnexal lesions, and evaluate for cervical motion tenderness or excitation that occurs in cases of PID. So these are the points that needs to be mentioned in the examination, and it will be important to be mentioned if the task appeared as a structured discussion task. In the initial investigation, please everyone remember that any case of bleeding, any woman in the reproductive age presented with bleeding, the first investigation that needs to be done is to exclude pregnancy, because this may be due to a complication of pregnancy. So the first investigation that needs to be done is a pregnancy test. The second investigation is to take vulvovaginal swabs to exclude cervicitis that may be secondary to chlamydial infection, especially if the woman is young age, less than 25 years of old, as we mentioned before. If you have suspicion of gonorrhea, plus the vulvovaginal swab, you will add an endocervical swab. And these swabs will not be repeated if it was already done by the GP. So now pregnancy test, vulvovaginal swab for chlamydia, endocervical swab if you are suspecting gonorrhea. And if the woman is more than 25 years old, you will do cervical screening test if the patient is overdue. But cervical screening is not done if the patient is less than 25 years old. If you have a suspicion in patient less than 25 years old, send her immediately for biopsy by colposcopy. But don't do cervical screening, and don't repeat the cervical screening if the patient is not due for cervical screening test. Once you have a suspicion and the woman is less than 25 or she is not due for cervical screening, send the woman directly for colposcopic biopsy. So colposcopic assessment is important in patient where there is suspicious cervix on examination. This patient will require urgent referral, and we'll discuss the indications later. Patient with post-coital bleeding may need transvaginal ultrasound scan and Bebel endometrial biopsy if the cervix is clinically normal and if there is coexisting intermenstrual bleeding. So what are the indications of ultrasound and Bebel biopsy? If the cervix is looking normal and the patient is having persistent symptoms coexisting with intermenstrual bleeding. If by the ultrasound you find that the endometrium is irregular or thickened endometrium, you will consider outpatient hysteroscopy, which has the advantage of visualization of the endocervical canal, and this outpatient hysteroscopy will be done if the symptoms are persistent in absence of other pathology, and by the scan you find that the endometrium is thickened or the endometrium is irregular. So as I mentioned before, if the swabs are done by the GP, there is no need to repeat these swabs as it is done in the primary care already. So now we'll finish what are the important information in the history, what are the important parts in the examination, what are the investigation step by step. Now, what will be the flow chart for management of post-coital bleeding? So you have a patient with post-coital bleeding. What will be the first step? As we mentioned, history, examination, and start the investigation. Take swabs, microbiology swabs, search for infection. If the swabs are positive, please treat the infection. If it is sexually shared infection, transfer the woman to the GUM clinic or to the GUM service for contact tracing and for screening of other sexually shared infection and for follow-up. So this is the first step if the microbiology swabs are positive. If the cervix is normal and the patient is having persistent post-coital bleeding or coexisting intermenstrual bleeding, in this case, you will consider, as we mentioned, an ultrasound scan and Bebel biopsy and hysteroscopy. If the cervix is looking normal, there is intermenstrual bleeding, and by ultrasound, the endometrium is thick or irregular. So in this case, you will consider additional Bebel biopsy and plus or minus hysteroscopy. If the woman is overdue for cervical screening and she is more than 25 years old, do the cervical screening test. If the cervical screening test is abnormal or the cervix is clinically suspicious, as we mentioned before, you will refer the woman for colposcopy. So now we can collect what are the indications for referral to colposcopy. So let's have a quick revision about the NHS cervical screening program and when to refer the woman for colposcopy. as we know that the new screening program will start by screening for the high-risk HPV virus. If the high-risk HPV is detected, we will do cytology. And if the cytology is abnormal, we will refer the woman to colposcopy. So what could be the abnormal cytology? If there are any borderline changes, if there is dyscryosis, either low grade or high grade, if there is any possibility of invasive cancer, or there are any glandular changes. So this is the first indication for transfer or for referring the patient to colposcopy according to the NHS cervical screening program. The second indication will be if you have two sequential inadequate samples. So two samples inadequate and two samples sequential inadequate, this is an indication to refer the woman for colposcopy. The third indication will be if the cervix cannot be identified by speculum examination. So these are the indication for referral to colposcopy according to the NHS cervical screening program. But women with post-coital bleeding have a different indication. If a woman with post-coital bleeding is presented with abnormal appearance of the cervix or the vagina on speculum examination, transfer the woman through the rapid pathway within 2 weeks for colposcopic examination. Even without cervical screening program, even if she's less than 25 years old. So if there is any abnormal appearance of the cervix or the vagina on speculum examination, refer the woman for colposcopy. If the woman is presenting with persistent symptoms of cervical cancer, like unexplained post-coital bleeding or persistent vaginal discharge, this woman has to be examined by an experienced gynecologist, and this experienced gynecologist may refer the woman to what we call symptomatic colposcopic examination. Symptomatic because the patient is having persistent symptoms in absence of clinical evidence of cervical cancer. So send the woman for symptomatic colposcopic examination, and this will be an indication also outside the NHS cervical screening program. So this slide is important to remember what are the indications according to the NHS cervical screening program and what are the indications outside the NHS cervical screening program in cases of post-coital bleeding. Now we finished the flow chart, how to take a history, what are the important points in the examination, what are the initial investigations in cases of post-coital bleeding, and then we discussed the indications for referral to colposcopy. Now let's go through a quick review about the possible cases of post-coital bleeding. We will remember together so many important points in the clinical practice and in the exam. So for example, in the case that appeared in 2023, it was a simulated patient task where the patient came with post-coital bleeding and she was diagnosed with cervical ectropion by the GP, and she had unprotected intercourse 12 hours back, and she received an emergency contraception which was not appropriate. We will discuss the case in details in the sexual and reproductive health module. But now let's discuss what's ectropion and what will be the management of the patient with cervical ectropion. So the ectropion itself is a normal and physiological condition, usually caused by cervical remodeling by estrogen exposure. It occurs when the glandular epithelium inside the endocervix is exposed to the ectocervix. By time, when this glandular epithelium is exposed to the vaginal environment, it will be transformed into squamous epithelium, and this condition, we are calling it into a squamous metaplasia. Who is at risk of having cervical ectropion? This is common after menarche, this is common during pregnancy, and this is common in women who are using combined oral contraceptive pills. That's why, as I mentioned, asking about the hormonal treatment and contraceptive pills in the information gathering is mandatory. So these are the patients who are at high risk of having the condition. Now, the symptoms. How are the women presented in cases of cervical ectropion? Many women will be asymptomatic, and this will be discovered only during the examination. But the possible symptoms include increased the amount of mucopurulent vaginal discharge. there will be post-coital bleeding, which is our topic today, and contact bleeding during speculum examination. Guys, if you have contact bleeding during speculum examination and you are not able to identify the pathology because of the bleeding, transfer the woman for colposcopy. This is another indication for transferring to colposcopy if inadequate visualization of the cervix because of contact bleeding or inadequate visualization of the cervix during speculum examination, send the woman for colposcopy. So in examination, the cervical ectropion or erosion, it appears as a red disc around the external os. Again, if there is contact bleeding that makes it hard to exclude any significant disease, refer the woman for colposcopy to confirm the diagnosis and to exclude malignancy. Now, what are the management options? The first option here, and this is a tricky point in the TOG article, because they kept it over the candidate and they kept it over the decision of the patient. So they mentioned, just reassure the patient that the condition is physiological, and the patient may decide not to have any further treatment unless symptoms persist. So here, when you are explaining this to the patient, explain that this is a physiological condition that can improve by itself, but if the symptoms are persistent, we may need to go for further steps of treatment. If the woman is taking combined oral contraceptive pills, change it into progesterone-only pills may resolve the symptoms by itself. The third point is cryocotary or diathermy. This is a treatment that will be used in patients who have persistent symptoms, but this treatment has complication and side effect. So the first of all, there is high incidence of recurrence, especially the woman is ongoing hormonal exposure. Number two, there will be copious vaginal discharge. There is increased amount of vaginal discharge till the healing process is complete, and rarely there may be cervical stenosis with its complication. Do we need to perform biopsy in cases of cervical ectropion or cervical erosion? Yes. If you have any doubt about the diagnosis, colposcopic biopsy is essential before proceeding to treatment. If you have any suspicion and you are going to treat the woman by cryocotary or diathermy, please do colposcopic biopsy first before doing the diathermy or cotary if you have any suspicion of malignancy. So this is the cervical ectropion. The second case that may cause post-coital bleeding is the cervical polyps. The cervical polyp, as we know, is a small pedunculated and fleshy lobular growth. It is usually found in the ectocervix, or it may be in the endocervical canal, or it may appear outside the cervix, but its origin is originally from the endometrium, and it will be prolapsed endometrial polyp. The causes of polyps, it may be due to chronic inflammation or abnormal hormonal response, and it's commonly seen in perimenopausal and postmenopausal women. Usually asymptomatic and discovered accidentally during examination, but it may present by post-coital or contact bleeding during the examination. So, how to diagnose? Examination. The polyp appears as a friable mass, and it's variable in size, but usually less than few centimeters. And by histological examination, it is essential for symptomatic polyp, and those with abnormal cervical cytology. So, do we need to do histology? Yes, you need to do histology if the polyp is symptomatic or the cervical smear is abnormal. Now, how to manage cervical polyp? Again, conservative management. If the patient is asymptomatic, it is suitable for this patient. The second is to remove the polyps, and the removal will depend on the size of the polyp. If the polyp is small, you will grasp it with a polyp forceps and twist it off till it comes out, and the hemostasis can be achieved by silver nitrate at the bleeding spot. But if the polyp is large or broad-based, this will require lobe diathermy at colposcopy. Sometimes you need to do hysteroscopic polypectomy and endometrial sampling. What are the indications? This will be indicated if the patient is having symptomatic polyp in the perimenopausal or postmenopausal woman, because this may indicate an associated endometrial abnormality like other endometrial polyps or hyperplasia, and this is common in 55% of postmenopausal women with cervical polyps will have endometrial abnormality. So hysteroscopic bulbectomy and endometrial sampling, if it is in the perimenopausal or postmenopausal age and the woman is symptomatic, there is 55% association with endometrial polyps or endometrial abnormality. And here the risk of malignancy in cases of cervical polyp is ranging from 0 to 1.7%. So that's why histological examination is important if the patient is only symptomatic or there is an associated abnormal cervical cytology. So now we discussed two causes, which are the cervical ectopy or cervical erosion, and the second is cervical polyps. Now another common cause of post-coital bleeding, especially in young age, which is cervicitis, endometritis, and pelvic inflammatory disease. Let's start by the cervicitis and post-coital bleeding. Cervicitis, it may be caused by STIs, and this usually occurs in young women. The most common cause is chlamydia, which occurs in up to 7% of women less than 25 years old. So let's remember the risk factors of chlamydia, as we mentioned before, less than 25 years old, if she's having a new sexual partner, if she's having multiple partners in the previous year, and if she inconsistently using the barrier contraception or the condom. How to detect it? By taking vulvovaginal swab or urine sample and nucleic acid amplification test. We have two options of treatment of chlamydia. Option one, which is a single dose with a better compliance, is 1 gram azithromycin. This will be followed by 500 milligram once daily for 2 days. The second option will be doxycycline 100 milligram twice daily for 7 days. And we mentioned that option one is better because of better compliance, because it is a single dose. In patients with chlamydia, there are important advices to be given to the patient. First of all, she has to abstain from intercourse until the treatment is completed. This patient, once diagnosed, has to be referred to the sexual health clinic for STI screening and for partner notification. The test of cure in cases of chlamydia is usually unnecessary unless there is poor compliance or the patient is pregnant. Now, if you are suspecting gonorrhea as a case of cervicitis, this is less common cause of post-coital bleeding. Again, the detection will be by the nucleic acid amplification test by vulvovaginal or endocervical swabs for culture. And the treatment here, again, single dose, but here the antibiotic will be ceftriaxone 1 gram intramuscular. Again, important advices here. The test of cure here is mandatory. We mentioned that the test of cure in chlamydia only if there is compliance concern or the patient is pregnant, but here the test of cure is mandatory in gonorrhea because there is increased antibiotic resistance. And again, any patient with chlamydia or gonorrhea has to be referred for the sexual health clinic for partner notification and further testing. Now, after cervicitis, endometritis, and PID. We all know that patients with PID will present with pelvic pain, fever, and abnormal discharge, and the treatment by starting immediate antibiotic, broad-spectrum antibiotic. And before starting the antibiotic, you have to obtain microbiology swabs for cultures. And if the patient is clinically unwell, she will need hospital admission and IV antibiotics. The antibiotics here, we will follow the guidelines of the British Association of the Sexual Health and HIV, and giving broad-spectrum antibiotics that will cover gonorrhea, chlamydia, and anaerobes. And all of you know what are the recommendations regarding the different types of antibiotics in the outpatient setting and inpatient setting. And I'm not going to waste the time here because this will be a different topic that will be discussed in the general gynae module in the PID task with Dr. Ali. Now, in cases of cervical cancer, as we mentioned before, the idea of investigation and management of cases of post-coital bleeding is to exclude the possibility of cancer. 3 to 18% of cases of post-coital bleeding will have a chance of having cervical intraepithelial neoplasia or cancer. So, most cases of cervical or vaginal cancer will be clinically apparent on examination, but still there are some cases where the initial screening was normal. That's why cervical screening program was very important, and once it started in the UK since 1988, the incidence of cases of cervical cancer has significantly dropped. Now the incidence is about 3,200 cases per year. So let's have a quick revision about the cervical screening program, which will start from the age of 25 to 64. And it is done every 3 years if the patient is between 25 and let's make it easier by saying 25 to 50. From 50 to 64, the screening will be every 5 years. But if the woman is more than 65, she can be screened only if she has recent abnormal cervical smear or positive HIV test. If it is normal, more than 65, there is no need for screening. If the woman is having HIV positive because of immunocompromised status, this woman will need to be screened annually, not every 3 or 5 years. Now the HPV and cervical cancer, the details of the HPV vaccine and HPV virus, you will find it in the task of the human papillomavirus vaccine in the PDF and in the YouTube. So the HPV vaccine is responsible for 70% of cases of cervical cancer, and it infects 70% of women during their lifetime. Most of the women will clear the infection by themselves, but if the HPV persists, it may lead to dysplasia and cancer, and the high-risk types of the HPV, which are HPV type 16 and 18, will cause 70% of cases of cervical cancer. That's why now the HPV vaccination is given for all boys and girls at the age of 12 to 13 years. And now they are using the Gardasil 9. The Gardasil 9 is protecting against 9 species of especially the high-risk types of the human papillomavirus with interaction with the other species. Now the treatment of cervical cancer or cervical intraepithelial neoplasia, if the woman is having low-grade lesion like CIN1, this woman, we can follow up this woman by screening after 12 months. But if she's having CIN2 or 3, this needs excisional treatment from the first visit, despite it has some complication, but still it is an indication. Woman with invasive cancer, this woman has to be referred to a specialized cancer center for the management. So this is another cause for post-coital bleeding, and is the main reason for investigation of cases of post-coital bleeding is to exclude the possibility of cancer. Again, quick revision about the vulval and vaginal lesions that may be a cause of post-coital bleeding. Cases of urogenital atrophy, it occurs due to estrogen deficiency, and it's very common in postmenopausal women. The symptoms include vaginal dryness, irritation, reduced lubrication, and dyspareunia, and occasionally post-coital bleeding, which is our topic today. By examination in cases of urogenital atrophy, the vagina will be dry and it will be pale, and there may be contact bleeding. The treatment options here will be in the form of lubricant, topical estrogen cream, dahlia, and laser therapy or osifen tablet. Now, the second cause of vulval and vaginal lesion is vulval dermatosis. Vulval dermatosis, we all know the lichen planus, lichen sclerosis, and the contacted dermatitis. And this again will be discussed in the general gynae module in details, but the cause of bleeding here will be due to skin fissures. So the general advice for patients with vulval dermatosis is to avoid irritants like soup, use emollients and topical steroids to reduce inflammation and improve the skin health, and the biopsy should be performed for any pigmented, ulcerated, or unresponsive lesions. So these are general advices. The lichen sclerosis, the risk of vulval squamous cell carcinoma is 4 to 6.7%. That's why cases of lichen sclerosis will need annual checkups. Now coming to the vulval cancer and vulval intraepithelial neoplasia. Usually the presentation will be itching or vulval irritation or palpable lesion or post-coital bleeding. The common appearance will be thickened white or pigmented plaques, or it may be wart-like growth, or it may be persistent ulcer. Biopsy here is essential. Any case of suspected vulval lesion, you should take biopsy, and this biopsy should include a transitional zone between the normal and abnormal tissue. Any case, if suspected vulval cancer, it has to be referred to a cancer center. Urgent referral to cancer center if you are suspecting vulval cancer. Now, vaginal lesions and cancer, vaginal intraepithelial neoplasia and vaginal cancer. Vaginal intraepithelial neoplasia is usually asymptomatic, but it may cause spotting or unusual discharge. Again, it may cause post-coital bleeding, and it appears as white or red plaque. The vaginal cancer, it will present as an ulcerated lesion, and usually vaginal cancer will be found in the posterior wall of the upper vagina. Both conditions, vaginal intraepithelial neoplasia and vaginal cancers, require urgent referral to colposcopy for evaluation and biopsy. So again, the main issue of this symptom or the post-coital bleeding is to exclude vulval, vaginal, and cervical cancers. The post-coital bleeding, it may be related to trauma. It may be due to vaginal tears, and these are common after intercourse that they may have, even if it is consensual intercourse. There is 34% incidence of women that are between the age of 20 to 40 years, they will experience vaginal trauma even if the intercourse was consensual. Here, the standard treatment, if there is traumatic injuries, will be the surgical repair if the patient is presented with active bleeding after intercourse. The last cause of post-coital bleeding is no cause or unexplained post-coital bleeding. This occurs in approximately 50% of women who are presented to the primary care with post-coital bleeding. In 50% of the cases, there is no cause. This woman has to be reassured that 60% of these women will experience a spontaneous resolution of symptoms within 6 months. But if the woman is having persistent symptoms with unexplained post-coital bleeding, again, this is an indication for referral for colposcopy and biopsy. So these are all the reasons of post-coital bleeding, and this infographic is giving a quick review or summary about the post-coital bleeding. What does it mean, and what is the incidence, and what are the investigations that needs to be done, and what is the management plan, starting from thorough history that includes the different points that we mentioned, and the other points in the examination that we mentioned, and also the initial investigation that needs to be done according to the presentation, and what could be the indications for referral for colposcopy, and the management will depend on the treatment of the cause. So again, this is a very important topic. This is a recurrent topic now in the exam. It appeared in previous November exam 2023. It appears in November, and it appears in May, and it appears also in November 2023. So 2023 and 2024, there are 3 tasks of post-coital bleeding. So it's a very important task, and we will discuss it in details during the sessions for the related module. So I hope it was useful, and it gave you a clinical or generalized overview how to investigate and manage cases of post-coital bleeding, because these cases are usually overlooked in the clinic, and it will end up by catastrophes despite the incidence of malignancy is low. But you need to be alert when you have a case of post-coital bleeding to properly investigate and treat the case. So I hope it was useful, As usual, if you find it useful, please remember me and my family in your prayers, and remember my brother, Dr. Absalam, also in your prayers. Thank you so much. See you, inshallah, in a next task and next discussion soon. Wassalamu alaikum wa rahmatullahi wa barakatuh.